prominent scholar and advocate, and very particular on mental health. So we are really privileged to have her to speak to us today. We hope that it will open up discussion later, and that if there will be required follow-up and follow-through, please take note, and the association, National Association, is more than happy to take it up when necessary. Okay. Without taking too much time, let me pass it on to Tuti, and welcome to Professor Kimura. And thanks again for being here with us. Colleagues, I happen to be in the field, so I cannot be with you. I will have to take care of other business, but my heart and my mind is with you. Tuti, over to you. Thank you.
Thank you. Thank you, Pak Puji, for the introduction, and welcome Miss Professor Mariko Kimura to this event today, International Lecture Series. It's actually collaboration, as mentioned by Pak Puji, between the Indonesian independent social workers and then universities, including the University of Muhammadiyah, Jakarta, and then other universities, including Binawan Universities and the Ministry of Social Affairs. We have several attendants here. There is Associate Professor Pak Ali Ekwatora dari Kementerian Hukum, ya Pak, and then other lecturers, and hopefully some will come join us during this afternoon discussion. So we are very happy to have you. Maybe just an introduction. I will introduce you to our audience today. So I will just read this. Just wait a moment. Sorry, I'll actually take a look on my phone. Okay. So Professor Mariko Kimura, we should call you Professor Kimura. She is Professor Emeritus at Japan Women's University and President Association for International Social Work Japan. So Professor Kimura is a distinguished Professor Emeritus of Japan Women's University, and her expertise is on mental health of immigrants, with an extensive academic work, including, and she has a PhD in social work from Wilfrid Laurier University, Canada, and also Masters of Social Work from Women's Japan University. I think I can't really read all your CV, but you are a very excellent speaker for today's discussion. I think talking about mental health, especially in Indonesia, is a very timely and crucial one. So maybe as happened in other countries, here in Indonesia, as for example, according to the research by the national data into 2018, there are about 19 million people have mental health problem, including maybe severe mental illness. So that would be around 9% of Indonesian population. And according to the same data, around 20% of Indonesian population have potential to have mental problems. Among young, like 13 to 17, something like that age, the number of mental problem is around 5 to 6%. So we just conducted a survey on mental health problems among high school students, and it's kind of like staggering actually on like the type of mental health problem, as well as the number of people who experience mental health issues. And when we ask question whether they would like to seek help from professional mental health, around 30% say yes, 30% say yes, and then from those who say yes, they actually seek help from psychologists and from mental health professional at school and from other places like hospitals. So like I have around 300 participants for this study. So from that data, actually, it's very obvious for us in Indonesia, talking and discussing about mental health is a big issue here. Especially when we talk about people or children in school, there are many cases of bullying and many cases of sexual harassment and also social media that creates stress and tension among young generation especially, and that can create mental health problems for them. So I think that's probably just an introduction so you could understand kind of like our like situation here in Indonesia. And then from your discussion talking about mental health in the community, that would be another big issue because as you may know, mental health services progress in Indonesia is kind of like stagnant. What I meant by stagnant is many people in Indonesia, especially in village, still consider going to traditional healer to treat mental health or mental problem. And in many cases, we people in Indonesia tend to ignore mental health issues because we kind of prioritize other things, including like food, education, etc. So that's probably, it could help you like put your presentation in our context, and we would like to learn from you how actually community mental health in Japan. So that's my introduction. So we now have like around maybe 17 people. So time for you, Professor Kimura, to start the presentation. Thank you.
Thank you very much. Ah, 間違った。いやいや。あれ Sorry. Can you see? Can you see the slide?
Yes.
Okay. This is okay. Thank you to T. Thank you for a very nice introduction and explanation of your society in relation to mental health. I'm really happy to be with you to give a talk today. And I thank Dr. Fujiono that he gave me this opportunity and share some of my experience. My background is mental health and mental health policy, both in Japan and also the immigrants' mental health, and also international comparison of mental health policy. And since my background, I studied in Canada, I learned a lot from Canadian experience. So let me start my talk. And then maybe later on, we can talk about your community, Japanese community, and in comparison with the Canadian experience. Okay. So this is the goal of the lecture today. Learn from each other, reflect on current world condition of mental health policies and the mental health social work with people with psychiatric disabilities. And at the same time, we'd like to recognize our cultural characteristics of our own community and compare that with others. And my experience in Asian countries in mental health field is limited, So with my talk through my Japanese experience and the Canadian experience, and like Tuti explained a little bit about the Indonesian mental health situation, we can discuss it later on. And if you have any questions in the middle of my talk, you could also ask questions. And okay. So the flow of the talk is like this. I'd like to introduce a little bit about the message from Mental Health Report, Transforming Mental Health for All. This is produced by WHO 2022. It is saying mental health is critical. And Japanese mental health policy and its problem, and Canada's mental health at the moment, it is said mental health for all. So it's not just limiting the mental health issue for the people with serious mental health illness, but also for all the people living in Canada. And some of the recommendations came from WHO report 2022. That stresses importance of building a comprehensive system, and it is critical to utilize the lived experience by the mental health consumers. I mean, those who have been going through the illness procedure, and enhancing recovery, not only receiving care, but help them to participate mental health service building, I should say, like support through support networks, human networks, friends, employment, education, and engaging other meaningful activities. That's the recommendation from the WHO report. In this report published in 2022, it says that transforming mental health for all. And mental health is like Tuti said, that in a lot of communities, both in Asia and throughout the world, that the country's priority is not on how people feel about their health and mental health. And other things like how to live and how to be successful in business and economic life and family life. Those are the priorities, and the mental health tend to put it on the side, and people would not talk about it openly. So, however, it is very critical that the mental health is probably the foundation of everything, every aspect of health and all the activities in life. So, and now that especially in Western countries, they've gone through the institutionalization process, and now all the state mental hospitals are closing down or shrinking to a very minimum size, and the people's mental health is treated in the community. So, and the focus of the emphasis of treatment of in the mental health field is shifting the focus. So not from treating illness, but focusing on how to live and how to provide effective support with those who have some mental health problems. So that calls on all stakeholders to deepen their value and commitment to mental health, work together to reshape the environments that impact mental health, and to strengthen systems of care for mental health is really critical. And the report also included the lots of survey and research results, and the mental health condition throughout the world is quite serious and critical. And I should emphasize point number 2. In 2021, depressive disorders pose the largest burden of all the mental health conditions, followed by migraine, anxiety disorders, and schizophrenia, which together made up of over 2/3 of the years lived with disability in the region, which means that the mental health is getting a very serious problem affecting the everyday life of people. And also it becomes a major problem of the whole health issue. And the mental health situation in Asia and other parts of the world, please look at the point, the third point. A consistent gender effect, women having higher rates of mood disorder and anxiety disorder, while men having higher rates of substance use disorders. So in the mental health, when I mentioned that illness and also the substance use disorders is quite critical when looking at the world situation. And throughout the world research, the findings confirm that common mental health disorders are highly prevalent globally, affecting people across all regions of the world. So it is very important for all the countries in Asia as well as Western countries, that it is really important for the government and for the professionals, including social workers, to start taking a look at the mental health issue as a serious problem, and need lots of work to be done. Talking about mental health, I would like to first talk about Japan. And this is the graph that usually taken to be introduced to the rest of the world. This is OECD data. And through this graph, you could know this. The psychiatric care beds per 100,000 population between 2000, sorry. How do I? It's a little bit older data, 2014 to 2016. However, the situation has not probably changed a whole lot. The psychiatric care beds in Japan has the largest number in comparison to the rest of the world. And in this data, Mexico is very small. However, Japan, there are over 250,000 beds in Japan. And then this number has not been decreasing very rapidly. And now the average length of hospital stay in Japan between 1993 to 2012. This is also from the Ministry of Health and Welfare data. And the hospital stay is also quite long, lengthy, over 290 days. And government is very aware of the Western trend, and the government has set the policy, try to discharge the inpatient to us in the last 7-8 years, I guess. However, the number has not been decreasing. And some of the reasons being like not enough community beds and not enough community facilities to receive the the people who want to be discharged. And also other reasons are like those who have been in hospital for a long time, they are not ready to get out of the hospital to start living in the community unless there's enough support in the community to introduce how to live in the community and engage in various activities. And social resources have been developed since over 20 years, I should say. However, this has not been successful. And one of the biggest reasons for the discharging policy is not very successful in Japan is that in many Western countries, the psychiatric hospitals are built by the government responsibility, so it's state-owned. So by shifting the institutionalization to discharge and into a community care, the government could shift the budget from hospital-centered budget to community-based budget. However, in Japan, since 1950s, government asked the private hospitals to build many psychiatric hospitals in Japan. So they want to keep the patient in their own property, which means the hospitals. And so it is very difficult for Japan to shift the population in hospital into community discharge. That's why, and this is a cynical remark. It says that the population who has been in a long hospital for many years, they are getting older and older. So if after 30 years, maybe the long-staying elderly will be passing away. So the population will be quite smaller in hospital. This is the remark that some of the policy researchers are analyzing. And at the same time now, there are lots of psychiatric hospitals which are owned by private. They are also taking dementic elderly people, and they of course keep them in a hospital. So the community trend is not really accelerating in Japan at the moment. So this is what I mentioned. Western countries, the mental health hospitals were built by the state. Therefore, under the institutionalization policy in the 60s, national budget was shifted from hospital to community. However, Japan was not like that. The government did not take the responsibility to build state hospital. So over 80% of the hospitals are owned by private. That's why the private hospitals, for economic reason, and they have been keeping the patients in hospitals. And even like lots of community programs are beginning to be built. However, some of them are built like with little apartments or some of the social programs. Some are built in a hospital yard or like a yard property, so that they just rotate the patients from hospital to community apartments, and then they have them engage in community activities within the vicinity of the private hospital yard. That's how it operated. However, like lots of social workers, here at the last point, more than half of the mental health social workers are working in community. That for this is a trend for over 30 years, I should say. Now, I'd like to shift the topic to Canada's mental health policy. So Canada has gone through this institutionalization process like other Western countries, started in early 20th century. And if you have studied the Western mental health trend, in Western countries, the beginning of 20th century, many institutions include not only mental hospitals, but also the institutions for the mental retardation, the people with disabilities, that it becomes very overcrowded, and the care policy was focused on just institutionalize and not for developing the progress of their condition. So the deinstitutionalization issue became the topic of those institutions. And provincial mental hospitals have been closed between 2070 to 1970 to 1990s. And the world community, the community mental health movement, you may have heard of it. Clifford Beers in United States influenced the community mental health movement. And there are lots of mental hospitals closed, and the care of the the place of care has shifted from institution to community. And fourth point, in Canada, the US influence was there, and also that in Canada, there's a response from the community that in Canada, the Canadian Mental Health Association is a very big advocacy organization. They provide mental health service in community, and also they try to collect the voice of the mental health consumers and the family members and the professionals, including social workers. And they influenced a lot on the Canadian mental health policy. And but surprisingly enough, until the beginning of this century, mental health policy was not the national policy in Canada. It's more like the responsibility is on the provinces, which means that there are 10 provinces in Canada, and each provinces had their own mental health policy, while health policy is a national policy in Canada. So this is the some of the data from Canada. And I only put the Canada data and Ontario, which is the name of the state that where the Toronto and Ottawa is the capital of Ontario, and British Columbia, the Victoria is the capital of Victoria State province. And you can see how the rated bed capacity of operating institutions, that you can see how the figure decreased sorry, that this is 1980 to 81. So you can see that in Canada's case, like for the 20 years, that there's a decrease quite a bit. And in the Ontario situation, there's also a decrease about 8,000. And in British Columbia, there's like over 3,000 beds decreased. Okay. And days of care per 1,000 population in 1980 to 1999, there's quite a bit of days of care decrease. So like in Canada, in total, minus 41.6, while in Ontario, about 40%, and British Columbia, minus 62. So there are lots of shifts happened throughout Canada, and the bed shifted to community, and days of care have decreased a great deal. And the shifting the trend from institution, state hospital to the general hospital in the community, and also the creating the community resources in each province happened a great deal even after 1980s to the 2000. So those things happened in Canada, throughout Canada, and also Ontario and British Columbia. And hospital length of stay is also occurred quite a lot. And this chart says days of care per 1,000 population in psychiatric hospital and general hospital, and the percentage of days care solely in psychiatric hospital by province. This also shows shifting the numbers. And the rapid shift has occurred in the British Columbia especially. And I spent 1 month studying the British Columbia system, and learned that how to shift the policy, and it's a lot to do with the people who are in political power to operate the what you call the policy in community. Since I mentioned that the state mental health hospital is run by the state, so that shifting the budget into community is once the policy is decided by the political administration. Throughout the Canada, all the states are like the same. And there are some differences in like rural areas, while the what you call the urban areas. And however, the policy shift has been in progress throughout the country. And this is the reported operating expenditures on psychiatric hospitals between 1970 to 1981. This also, the psychiatric hospital budget has been decreased quite a lot, while in the case of British Columbia, in the here, it has not been decreasing yet. And the table 6 reported operating expenditures on psychiatric hospital and per capita unit in general hospital. And here you could see the budget shift from psychiatric hospital to general hospital. That's how the budget has been shifting. And the figures may be difficult to just follow. However, that some of the impact from social work and community mental health movement is impacted a lot to influence the state mental health policy. And this is the case for the province of Ontario. As I mentioned earlier, Canadian Mental Health Association have been very active as taking a role of advocating the mental health consumers and the mental health family members. And social workers has been very active working with Canadian Mental Health Association since 1950s. And especially after the deinstitutionalization policy became the major current of the mental health policy throughout the country, the Canadian Mental Health Association held a lot of national conferences and tried to listen to the voice of the mental health consumers. And and the social workers and the staff of the Mental Health Association, they try to influence the provincial policy in mental health area. And this key mental health services support a comprehensive care system. This is the policy that put the Ministry of Health Ontario in 1994. There are lots of comprehensive elements in the mental health policy in the the province of Ontario. So at the provincial level, the forensic service, the people with mental health problems, but also commit crimes, that's a provincial level responsibility. And in the province, they divide the district health level in what you call the prefecture, I guess, and the specific category in the professional service. For example, dual people with the dual diagnosis provide a specific category and professional service. And long-term care for serious mental illness. Still, the rehabilitation service and community reintegration service is district health level responsibility, which means they have to create resources to the mental health programs and how to integrate the people in who are living in community. But at the local level, very, very close to where people live, there are lots of agencies built to do lots of work, like assessment, referral, short-term hospitalization plan, 24 crisis intervention, emergency care, treatment and care, case management, housing, consumer user initiatives, income support assistance, social support, and family support. These are done in a very close to where they live at the community level. And that range of different services at different levels are coming together to be integrated part of the mental health service as a comprehensive service. And throughout Canada, I should say. And this is the framework for support. This is the diagram made through the voices of the participants of the Mental Health Association of Canada National Conference. Like this is the image that sort of like wrapping around the person who has some mental health difficulties, and the resources like housing, work, education, income need to be placed in place, and their person is surrounded by consumer groups and organizations and family and friends, mental health service, and other community service and organizations are surrounding them. This is the image that put forward by the mental health consumers at the conference. However, the province of Ontario, they took it as a state policy and tried to integrate it into the state mental health policy. How it developed the mental health policy of the state. And eventually this kind of image as a more how to put into a policy in an actual way has developed throughout to Canada. So this is a very big progress, happened in 1980s. And now we are living in 21st century. And as you know that we talk about SDGs through at various occasions in social work conferences. And this fall, I guess, there's a conference in Sri Lanka, the IFAP conference, that we will also talk about the environment and sustainable development goals at the conference. But SDGs started at the beginning of 2000, so it's halfway through, and it will have another 15 years to go. No, I'm sorry, the 7 years to go. 2010, I guess, started. We had MDGs before, but at that time, the mental health issue was not in the development goals. And in SDGs, for the first time, mental health put into like a sustainable development goal, and the mental health issue as a key issue to be achieved as part of the health, but also the mental health as itself has become the goal of itself in the SDGs. And from WHO, again, I'd like to mention WHO Mental Health Report 2020. What's innovative in this report is the definition of mental health. In this report, it is said that the mental health is defined as a state of mental well-being that enables people to cope with the stresses of life, to realize their abilities, to learn well and work well, and to contribute to their communities. This is not the definition and elsewhere. This is a new way of defining mental health, and try to convince people, policymakers, people in specialized profession like mental health, like hospital, medicine, social work, psychology, family members, that this is like mental health is a core element that affects everybody's life, including community life, family life, work, quality of care, and everything. So the mental health definition in this WHO report is quite innovative and new. It does not, it may not look new maybe to us social workers, but it is very simplified and a very convincing way of defining mental health. So in another word, mental health is an integral component of health and well-being, and it is more than the absence of mental disorder. So, and another aspect, what's innovative WHO report, the mental health definition, and also the report itself. I would like you to read it, especially the chapter 7, because it is very right in a very basic way, and also the convincing, try to convince the reader it is very important to focus on community, and also very important to everybody to participate, including mental health consumers, to build a very comprehensive service programs and mental health, what you call the programs in a comprehensive way. So those are the key elements, which are like focus on user participation, recovery focus, user input is very essential, comprehensive community care must be developed, and the focus on community. In most of the Western world, the deinstitutionalization has completed, so the care is taking place in community, and also the services provided through community based on the national mental health policy. So, like this is another data put by Canada's mental health process of change and shifting beds from provincial psychiatric hospital to community between 1987 to 1996 in British Columbia. And in British Columbia, they decreased. This is the plan based on, and it's probably the process is still going on, but according to their plan, by 2013, which is already passed, the state hospital beds should be decreased to 0. And community tertiary medical organization plan that actually try to increase. And emergency psychiatry is set their goal to a certain number. And the crisis housing should be increasing. And supported housing should be like between 1987 to 1996, it should be 10 times more. And then now it should be more. And the housing with care, like it's about to stay the same. And the family-like care living situation, those who have difficulty living by themselves, this is not very many. I think the number is still short. And the emergency shelter should be increased. And also total number of housing, altogether housing and mental health facilities should be increasing more, because since the hospital beds decreased to almost zero, so like in these 10 years, the beds have been increased about 2,000, so it should be more in here. So like in Canada, this is an example of British Columbia, interventive approaches for specific groups. Since the mental health policy in Canada, that there used to be the focus was focused on the people with serious mental health illness, like major depression and schizophrenia, those people, or people with the dual diagnosis for the serious mentally ill. However, now the goal has been somewhat accomplished, though still not enough. So the country, throughout the country, I think the mental health policy is focused on promotion strategy, how to promote the mental health and mental health for all, how to achieve it. And the specific prevention, crisis harm reduction strategy is like this, the twisted triangle is like the quantity should be focused on number 4. So, and number 3, and specific prevention, like they focus on prevention. And the mental health addiction, heavily vulnerable people, the focus should be on this area. And the treatment intervention from heavy level, mental health addiction, mildly vulnerable people, it's like the priority is lower. And the treatment intervention, heavy intervention, very, very seriously mentally ill people, the number should be smaller, the focus. So like the societies and the national policy focus is on prevention and the information giving, so that people have more access to mental health service rather than keeping them in institutional care. So Canada's mental health policy after 2000 focus more on people with health promotion. And also the Tuti mentioned that in Indonesian community, the youth and children's mental health is critical. Like Canada is saying the same way, because it's like early intervention is very, very important. How to treat them so that the illness should not become very serious, and they learn how to treat it in the early stage so that they can participate in a community life. And also they have a big indigenous population, so that and they have a high rate of alcohol and suicide problems and drug problems. So that indigenous people's mental health is also very important. And so that shifting from serious mental illness to all people and their mental health is the national goal for mental health. And the great needs for people asking mental health treatment information, so that they try to do search for effective way how to deliver mental health service, which is the next point. Utilization of modern technology providing mental health information and treatment information through internet. Government is putting a large number of budget into developing the internet system to provide information how to have access to treatment or how to care and how to understand the mental health illness and mental health and mental illness. Because the mental health professionals number is limited and in a society, and meeting one by one, they cannot solve all the mental health needs, so that they try to utilize the modern technology how to deal with the mental health issues. So now in Western developed countries, including Canada, mental health policy became part of the general health. This is a Canadian mental health policy, so that the great need for everybody's mental health is there. And Canada completed the institutionalization, and now they focus on community service, and the budget allocation has shifted from psychiatric hospital to community, which is quite different from Japan's case. Japan is still lots of money put into psychiatric hospitals and the hospital service. So now getting back to WHO report of 2022, recommendation from WHO report. As I mentioned, Canada's mental health policy is mental health for all the people, I mean. And recommendation from WHO report, importance of building a comprehensive system is very important. And we have to utilize our knowledge. Like every country, every community may be different. So we need to utilize our knowledge based on our culture to how to build a comprehensive system, maybe like even with a limited resource in the money-wise or personnel-wise. And it is critical to utilize the lived experience by the mental health consumers. The mental health consumers are not just the people who receive mental health service, but to utilize their experience of recovery, and they know how to, they should learn or work with the social workers or mental health workers, how to utilize their recovery experience to help themselves and also help other people who are suffering from mental health problems. And people need not only receiving care, those who have gone through the illness, but also building support networks, human networks, friends, employment, education, engaging other meaningful activities. Those are the goals that should be built into a comprehensive system. Okay, this is the end of my presentation. Thank you very much.
Okay. Thank you, Professor Kimura, for your presentation. So I will just actually summarize in Bahasa, in Indonesian language. Hope that's
Yes,
okay.
yes, sure.
Yeah. So, saya akan sedikit mensummary ya, highlight dari yang disampaikan Profesor Kimura tadi. Jadi, Profesor Kimura menceritakan bagaimana development treatment terhadap kesehatan mental di beberapa negara, terutama di negara barat. Yang dikutip adalah di Kanada, sesuai dengan studinya Profesor Kimura, tapi kemudian beliau juga menyampaikan apa yang terjadi di Jepang gitu. Nah, jadi yang menarik di sini sebetulnya ada beberapa hal. Pertama adalah saya mencatat yang umum-umumnya aja. Ada tren yang sangat luar biasa di Jepang yang itu sebetulnya psychiatric beds atau orang yang yang di treatment di hospital itu sangat tinggi di Jepang, yang mencapai 250 per 100.000 population. Kalau kita bandingkan dengan Indonesia, saya nge-google sebentar tadi, kita hanya 6,3 orang per 100.000 population. So, Prof. Kimura, so I just mentioned that while you said that in Japan there are 250 psychiatric beds per 100,000 population in Japan, I just searched actually in Indonesia we only have around 6.3 psychiatric beds for 100,000 population. So it's actually very, very small. Under it can actually meaning a lot of things, right? Under treatment, under care, but also it's actually a significant indication that actually people take care of those illness in their own in their own houses or families, within their families and communities. That's actually one thing. Terus Prof, actually one thing that is very interesting from what you mentioned in your presentation is about the institutionalizations of hospital care to community care. Jadi yang disampaikan Profesor Kimura adalah tentang significant change atau shift ya, perubahan dari awalnya adalah treatment di hospital itu kemudian berubah trennya menjadi treatment di komunitas. Nah, seperti apa di komunitasnya sebetulnya tadi tidak terlalu secara detail meskipun tadi disampaikan apa yang dilakukan di local level terkait case management dan sebagainya. Tapi shift itu kemudian mengindikasikan banyak hal. Misalnya mungkin treatment di komunitas lebih murah daripada di hospital gitu. And then you mentioned that the tendency of privatization in Japan is huge. That's actually a sign that government themselves actually couldn't provide enough services for those in needs for psychiatric care. Then they actually refer it to private companies or sector. This could be very problematic when we know what the private sector do to get profit, for instance. But that's actually another discussion.
That's right.
Actually very interesting also. And it's just, as you said that ini masih tren di Jepang bahwa privatization of hospital bed for treating mental problem it's masih terjadi saat ini. Seperti itu. Nah, Profesor juga menyatakan tentang selain deinstitusionalisasi itu tadi tentang bagaimana sih yang terjadi di community reintegration services ini. Tren bahwa ada treatment mental illness di community itu bukan hanya ada di Kanada dan di Amerika, tapi juga ada di negara-negara lain seperti itu. Nah, yang terakhir paparan Profesor Kimura itu terkait dengan tadi sebetulnya kalau kita di social work itu you actually describe really well on how the concept of person in environment in the framework support for mental health policy in Ontario, right? The one like in is a person and then around it it's about housing, work, hospitals, etc. So that's kind of like a concept of person in environment. And your last presentation about mental health as one of the SDG goals since 2015, we have that in the SDGs, but you also mentioned on the shift on definition of mental health according to WHO report. Jadi yang terakhir Profesor Kimura menyampaikan bahwa definisi mental health itu adalah bagian dari kesehatan dan well-being atau kualitas hidup kesejahteraan yang baik. Tidak hanya absen dari mental illness atau mental disorder. Jadi kondisi mental health itu sangat integral dengan kondisi kehidupan yang layak, kehidupan yang berkualitas, dan kehidupan yang baik. Dan you actually recommended us to read WHO report on mental health, and you said it's very good because there are focus on user participants, etc. Jadi kita direkomendasikan untuk membaca WHO report tentang bagaimana mental health menurut WHO yang menurut Profesor Kimura itu sangat bagus dan bisa diimplementasikan di negara kita. Now, I think that's actually your presentation. I tried to summarize it, but actually before I give it to floor, I have actually 2 questions for you, and I can give it to everyone here to ask questions. First, actually, when you mentioned about deinstitutionalization, how that actually affect mental health services in general, because as you may know that if we put it to the community, how they actually, what is the standard, whether actually only those in like mild symptom treated by the community, like I don't know, like what's the standard for those countries who shift from hospitalization to community service, and what it looks like, whether actually community services for mental illness, meaning there are doctors there available, social worker, or actually there are communities who also help take care of those with a mental problem, like let's say volunteer, for example. So what that look like in your country for community services for mental health? And then whether in your opinion, the institutionalization because of cost of treating mental problem, it is cheaper for government to put it in the community to treat those with mental illness. And one question about Indonesia, since this is actually very timely. In our country, it is still common for us to treat those in mental health, who have mental health in our own home due to stigma, etc. So if you just bring your child to psychologist or to psychiatric, there are, stigma that, oh, you have mental problems, something like that. So how actually you deal with that? So that's actually my 3 questions. I give to the floor, or you want to respond, or we'll just let the audience to ask questions first.
Okay, thank you. First, I answer to what you said about the stigma. I think, as I said, the WHO report and many things that in lots of developed countries, that the mental health becoming a little bit shifting the notion of people. It used to be with a high stigma attached to it. However, that many people have become aware that they're in a long lifetime, they have experienced some sort or another of mental health problem through their lives. And lots of people have suffered from depression and not even slight, more like a somewhat moderate level of mental health problems in a daily life. And it really affects the economy and production of work. So that all the countries began to take mental health issue as a serious issue. So the stigma is somewhat decreasing, though in case of Indonesia, or maybe it's still a high stigma attached. So even in Japan, it's like it really affects the production of people's work performance. So the society and the government is beginning to take it more seriously about the mental health problem. So that's the stigma changing. yet still the social workers are working on anti-stigma promotion activity, because try to people understand the mechanism of stigma and the mental health problem is very critical, so that people feel easy to ask for help. Otherwise, if they keep surrounded by the stigma of mental health issue, they can never go to the treatment, and their illness becomes more serious. And that affects the production of the economy. So that's it. And now about mental health service, the shift of institutionalized service to community. There used to be a discussion that if the service is provided in community, maybe the cost may be lower. However, it is actually not the case, because they have to make the similar type of all the service in community in the different places. And they actually, the building facility and placing people at different locations, the cost will not be so cheap. And there's a lot of different type of skills needed. And it used to be like one institution, and there's all the medical staff in one facility. So they didn't have to have the case management or anything like that. They are surrounded by the wall, and all the patient was are in the wall. However, it's now the wall is taken out to shift it into community. So there are lots more work of coordination, make sure the service is done properly. And this type of different kind of skill and role taking by different professionals, they need more coordination, and also sometimes the role is very required in the mental health service done by community. And also lots of housing needs, because if they have to put them in the institution in one wall, they were put in different rooms, and they don't have to have any other housing, right? And all the services were provided in one wall, within the wall. But now all the services are placed in a community. It requires a more complicated and system that are required. So it's not cheaper at all. So I hope that answers your question.
Okay. So thank you, Professor Kimura. So please raise your hand, Bapak Ibu. My colleague Pak Teguh Zuliadi from Aceh, Pak, silakan, atau Pak Ali jika ada question. We have question in the chat from Pak Samsudin. The question is there any specific training for certification for a social worker to handle mental health cases in Japan or Canada? So that's the question from our audience, from Pak Samsudin. It's in the chat if you want to read it.
Yeah, is there the specific training or certification for social worker to handle mental health cases in Japan or Canada? I think in the US, lots of social workers, a major area of work is focused on mental health. However, in Japan, we have two social workers training system. One is generic social work, and the other is mental health. So that I think 1/3, maybe the number for mental health social worker in Japan is 1/3 of the number of the generic social worker. And it's very unfortunate, because generic social workers, that lots of mental health portion is not in the training system. So they feel not hesitant to intervene with those people who have mental health problems. Like those who are trained as a mental health social worker, they are used to working with people with mental health problems, and they feel okay, but the generic social workers, they don't want to even talk about it very often.
Oh, oke. So, menurut Bu Mariko, Bu Kimura, bahwa dari pekerja sosial itu sepertiganya generic social worker, yang selebihnya ada mental health social worker. Nah, yang generic social worker katanya tidak terlalu ingin menghandle masalah mental health problem, bahkan tidak mau membicarakan itu. Jadi hanya yang comfortable atau yang biasa menghandlenya adalah yang memang mental health social worker. We have please Bu Yustika.
Thank you, Ms. Tuti and Universitas Muhammadiyah Jakarta for facilitating this meeting, and also Mr. Mariko. Actually, I'm Yustika. I'm a PhD student in social welfare at Unpad, Universitas Pajajaran. So disregarding the issue, first of all, I would like to share that from Bandung, one of the cities of Indonesia, it's here mental health remains a significant challenging, especially due to the government's lack of concern and limited resources allocated addressing this mental health issue. So given this situation, once I work on providing the free counseling service with a social worker. And however, with the severity of some cases, we often had no choice but to refer them to a more professional one or a psychiatrist. So the problem is that the psychiatrist service are paid and kind of expensive. So could you provide me some input or strategies on how to address this challenging beside the free counseling services, because the community, I think it's the first move to touch the grassroots by with the providing free counseling service. Thank you.
In Japan, the health service is covered by the national health insurance. I think that 70% of the medical cost is covered by the national health insurance. So the cost is not very high. However, the problem is the family members is having a hard time understanding the mental health issue and the mechanism of mental illness. So when someone has a mental health problem and it becomes serious, and then the person is becoming somewhat violent, or the unbalanced way of living, it is very difficult to intervene unless the family is understanding of illness or what, and often that is a case that the person developed the level of illness is becomes serious, and then the person is delivered to a psychiatric hospital by emergency car, ambulance. Yeah, so that's very difficult because that experience is very bad for everyone, right? So it is, I think, health promotion is for everyone to understand that it is easy for us our condition to become imbalanced in a various situations. Sometimes we have and then sometimes that becomes serious and continuous, and then the person may become somewhat ill, and then there's where you can go for counseling, or not just even counseling, but more like treatment sometimes needed, or sometimes medication is needed. Not just the counseling solves everything, right?
Yes, of course. But so luckily, Japan has an insurance to cover the mental health issue, right? It's not, I think, not really happening in Indonesia right now.
Oh,
But thank you for all the insight, Ms.
Yeah.
Mariko. Thank you, Ms.
Yeah.
Tuti.
You are welcome. There's another question. And what is the kind of intervention or therapy from social worker to help client with mental health problem? Seems, shall I answer?
Yes, please.
Oh, okay. I think most of the skill that the social workers acquire through mental health social work training is like how it's similar to the generic social worker skill of listening, but also understand the mechanism of mental illness or the relation to person and the environmental relation. When the stress is there, the person become easily not stable, right, in a mental health condition. So like when social workers assess the person that that person needs care, then the social worker will probably refer to psychiatrist. So they social worker recommend the person to go visit the hospital so that they can be treated properly with some proper medication. And sometimes the rest is needed so that the hospital or doctor may recommend hospitalization in a short time. And then if they take medication and the rest, and then the person may be okay. So that collaboration among the professionals, not just social workers who work themselves independently, is the way. And also, I think other factors like the money, poverty are also affecting the mental health of the person. So those some kind of social service that is social security or social service. So the social workers, what they do is what kind of service besides the medical service is available. And if they have other issues like losing the employment and those kind of service referral is also critical, I think, for disability pension. Yeah. Okay, thank you.
Professor Kimura. Yes, actually, one important thing that you mentioned that on the health coverage, health insurance coverage earlier, yeah. So I actually need to check if Bapak Ibu know here whether our BPJS, our universal healthcare in Indonesia, we call it BPJS, whether it covers mental health treatment. I don't know, probably not. I haven't actually checked on the BPJS services of they cover mental health. But you also mentioned on the intervention that was asked by Pak Samsudin on most of skilled social worker can be used or utilized for the mental health services. However, unfortunately in Indonesia, I don't know if it is in Politek Kesos, the student received the DSM for the clinic, DSM subject. But in many universities, maybe they don't offer that type of course like DSM-5 especially. But what I experienced in US, those who actually specialize, because in US, they have to be in master level, right? To be licensed later on. So those who are in the master's program and they will go into clinics, clinical social worker, they call it clinical, not mental health. So clinical social worker, they will get DSM and other clinical course in the subjects required for the master's level. However, most of the master social work students in US also has background in psychology. That's why most, like 80% of master social work students in US specialize in clinical social workers. So I don't know, probably that's also the case in your country, in Japan.
Let me answer. In Japan, most of the social workers training is done at the undergraduate level. So like even mental health social worker, they don't teach DSM, though there may be some professor in some courses, they may defer DSM. However, in Canada or United States, yeah, like you said, most of the clinical social work training is given at the master's level, and they certainly study DSM. So it's different. Japanese social worker, including mental health social worker, like the social workers in North America. So I think that the social workers in role in Japan, they do more like involve them to referral services, social programs, and the social social support, service, and the monetary service, and the programs that they introduce, and also like recently there are lots of social work agencies related to mental health in community. They try to help them refer to work training programs, because that some of them feel very insecure without work. But at the same time, if you earn too much money, then the money is taken by as a tax. So it's like a very difficult situation still. It's not very well developed yet.
Okay, it's interesting you said that most social worker in Japan train in undergraduate level, like you said. So then we are in the same case then, in the same boat, because most social worker here train in undergraduate level, and even for the Independent Association of Social Workers, then they only recognize those who have undergraduate in social work. Yeah, because maybe in Indonesia, not many universities offer master's level. So that's one of the reasons. Okay, we have another question from Ibu Hastin. Bu Hastin, do you wanna actually open your mic so you can ask question directly, Bu Hastin? Bu Hastin is PhD student at the University of Indonesia, my colleague.
Yes, Hastin.
She has actually question in the chat.
Oh,
here.
okay. Are there more effective approaches for social work to raise mental health awareness in community with specific cultural or religious beliefs? This is very interesting question. And we, in Japan, we, through my interest in international social work, I'm very interested in people who have different cultures, and that who may have some affect the mental health in living in different lives. The raising mental health awareness is done through public health department, through the Ministry of Health and Welfare in Japan. However, the mental health promotion is not socially widely integrated in Japanese community. At the workplace, there is a mental health check programs at the work, because they don't want workers to take long absence. So the mental health check is becoming their interest in terms of maintaining the mental health of the employees. However, the mental health promotion, we still need to learn from those countries who have been successful in mental health. I think one of the things I mentioned, I think the government should put more money into to have more mental health, releasing mental health knowledge through internet and not just the money-making way. I think they should. It's their duty to do it. The government role to have a more promotion of mental health. I think it's done in a very limited way in Japan, but in northern part of Japan, where the weather is very severe, and I think people with lots of snow, which is not case in Indonesia, but people feel high rate of alcoholism and also a high rate of depression and a high rate of suicide in northern part of Japan. So I think it's a very suicide prevention and the mental health promotion in that area. We have not been very successful yet, but I think that health promotion and suicide prevention and public health, utilizing public health model is more effective than doing one-by-one counseling. That's what we found. It's not a very good answer, but the model is should be a public health model. Okay, so try do one. Thank you, Kimura, for excellent presentation. Thank you, Indonesian colleagues, for organizing. This is not question.
Yes.
Okay.
Okay, Bapak Ibu, if you have any other questions, please raise your hand and then you can directly ask Professor Kimura. One thing you mentioned about community health services, actually, community mental health services, I was actually kind of like surprised that you said, oh, actually the cost is higher than the hospitalization, than the inpatient in hospital services. So that's actually very interesting. And like you mentioned that, oh, they need housing, or they need actually enough standard. I mean, there are standard on how to build community mental health facility, something like that. So that's very interesting. Actually, in Indonesia, not that many, probably. Yeah, there is actually one, let's say, one organization in Bogor, but that's mostly community based. So donation from communities, not government built community mental health services. So yeah, government have several hospitals to treat mental problems. Okay, please, Bapak Ibu, if you have other questions, we are now 2:40. I don't know. Bu Meti, do you have questions? Please, if you want to raise any issue or question, because I think it's very interesting discussion. Silakan Bu Meti, Diana.
Hello, I'm Meti from Banjarmasin. Actually, there are so many questions that I have, but I confuse what kind of question that I want to address to Professor Kimura. Actually, in Banjarmasin, community mental health nursing isn't run as it's supposed to be. So I think it because of so many factors like money maybe, or there is no apa ya social worker and maybe the limitation of knowledge of our mental health nursing. So I think we are in Banjarmasin need to apa ya have more motivations. Yeah, have more motivations. So the community mental health nursing can run as it's supposed to be. Yeah. Thank you, Prof. Mariko, for your great sharing today. Yeah. And actually, my questions are the same like Ibu Hastin. It is regarding community mental health nursing. How can we improve community awareness regarding mental health? Use cultural or spiritual based psychoeducations. What the first step that we have to take? Yeah. Yeah, that's maybe my questions.
Okay. I've been in this field for over 25, 30 years. And I'm beginning to think more and more that nowadays that treatment modality is changing a great deal from before. That people take medication, but they keep working and they continue even like the early psychosis in junior high school. They may take medicine, but they keep schoolwork. And some people may continue work by taking medication. So like it is very important how the support is there to the person to maintain the quality of life is very important. So it's not like they used to stop working, they put them in hospital and they stay in hospital for many days and come back and then they rehabilitate and they try to get back to work. That kind of process is unnecessary, but how to support the daily living with having the illness within the person. That kind of modality is very important. And also like, so how to support them to engage themselves in a meaningful way of living, like school or work or friends or creative, some kind of hobbies or socializing, but try to the proper way of support of mental health, and also persons themselves are aware of their own condition, how to take care of themselves or the family, if there is family who can provide the proper care. That kind of way of thinking, wrapping around that person who have some mental health problems is very important. But sometimes like a family can be somewhat stress inducing. So I'm not sure that staying with the family is always the best way, how you maintain the relationship with the family, friends, environment, I guess. So like some kind of actual service or build a service in community so that person can utilize them and the social workers can coordinate them is very, that way of thinking is probably a good way of thinking. Thank you.
Thank you, Professor.
Terima kasih. Thank you, Professor Kimura. If any one more question, I think we could end at 3.
That's it.
Dulu tentang order kemarin itu seperti apa sih? tentang data.
Hello, I think if no other questions, maybe we can end the discussion for today, Miss Prof. Kimura. Pak
Yes.
Puji, are you still there? Do you wanna give a short remark for the ending, for the closing?
Who?
Pak
Myself?
Puji, I don't know if he's still there,
Puji.
but he's
Okay.
still there.
Puji is still
Yeah.
there.
Yeah. Any other from Politek Kesos or from Unpad? My friend from, you know, right, the very west part of Indonesia is Aceh.
Mhm.
So my colleague from Aceh University in Araniri, also here. Dena, do you have some questions? Yeah, Dena, do you have questions? Yeah.
Good, Bu. I just joined the meeting. Halo Bu Tuti, halo Pak Puji, halo Prof Kimura.
Hello.
Oh, you are muted. Do you have question, Dena? Masih di mute. Oh. Dena masih mute.
No, Bu, I don't have any question actually.
Oh, okay, yes. I think probably that's all our very productive discussion today. I think we highlight very important topic on mental health problems in as you presented in several countries, but also how it is relevant for our context in Indonesia. It's very good, Pak Puji. I think if we could summarize our discussion, and there are issues on how actually health insurance work in Indonesia for treating mental health problems or mental illness, how it works for community health, mental health services in Indonesia, whether it actually exists here or it just, I mean, like traditional way to treat mental illness still will be the majority of the cases in Indonesia, and how actually government policy on mental health issues in Indonesia. Those three things probably we need to work on, and maybe also Professor Kimura, for your information, now in Indonesia, those who have mental illness mostly treated by psychologists or psychiatrists. So either they go to psychologists or psychiatrists. Very few, I think, social worker who handle mental health cases in Indonesia. Just because probably we are not really trained to serve the people with mental health problems. Not like in other developed countries who really have either mental health social worker or clinical social worker. I think that's probably just a very short summary from me. Any other closing statement from you, Professor Kimura, please?
Yes, I think that treating the mental illness or mental health problem part, psychiatrists and psychologists can deal with it. But how to have them live with mental health problems, the social workers can offer a lot. And creating community resources where the people with mental health problems can gather together, have talk about their difficulty, how to went through, how to recover. That kind of work is very critical after the illness, and the social workers can do a lot with it. So I think I hope that social workers can start talking with psychologists and psychiatrists. Like they are treating the illness part, but maybe not the rehabilitation part. But the social workers can work with the rehabilitation worker as well, I think, or occupational therapist or physio. Yeah, I think so.
Yeah, I think that's very good closing remarks from you, because that's actually signify on differences our role as social worker, then psychologists and psychiatrists, and how we could be complementary to the role of mental health providers. here, like you said, like how to live with mental health problem, what community services available, something social worker do. That's a very
because the mental health problems may not go away. They
Yeah.
usually stay there with the characteristics of the individual personality. So they have to learn how to live with it.
Okay, I think that ends our discussion. I hope you enjoyed today's discussion, and we will see you again in the next international lecture series. Thank you all. Have a great afternoon. Okay, bye.
Bye. Thank you.
Professor Kimura.
Yes. Thank you. Bye-bye.
Bye.
See you next time.
See you.
Um,